Good evening, Dr. Phil here. Today we will be discussing on interscalene block. General principles of nerve blocks. First, we should do a full anesthetic assessment, which includes history, examination, and investigations, and obtain a valid consent. Indications for nerve blocks includes to avoid general anesthesia due to poor health, post-op nausea vomiting, or desire for early discharge from hospital, early return to normal diet, especially in diabetic patients, for post-operative analgesia, which allows effective physiotherapy, improvement of blood supply to the surgical area, and early immobilization of operative area such as tendon repair. Contraindications for nerve blocks includes absolute and relative contraindications. Absolute contraindications are patient refusal, infection over needle puncture site, and local anesthetic allergy. Relative contraindications include coagulopathy, general sepsis for neuraxial block, uncooperative patients, and peripheral neuropathy. Performance of the block. Full resuscitation facilities must be available and full monitoring according to AAGBI standards. Available personnel should include anesthetist, assistant, and a person to provide emotional support to the patient. Equipments needed includes the ultrasound, resuscitation drugs including intralipid, nerve stimulator, insulated short bevel needle, oxygen supply, local anesthetics and additives. Calculate the required dose and do not exceed maximum local anesthetic dose, etc. Confirm consent and site of the block, sedation with midazolam and fentanyl, aseptic technique, don hat, mask, gown and gloves, prepare the skin with 0.5% chlorhexidine in 70% alcohol, and wait until the skin is dry, and drape. Analgesia includes fentanyl and subcutaneous injection of 1% lidocaine at the point of needle insertion. Techniques includes the ultrasound-guided technique with or without nerve stimulator and landmark technique with nerve stimulator. Avoid intraneural injection to reduce the risk of nerve trauma. Using ultrasound guidance, reposition the needle if contractions occur at less than 0.2 milliamps during nerve stimulation. Impulse duration should be 0.1 millisecond, set at 1 to 2 milliamps initially. As the needle approaches the likely site of injection, decrease down to 0.3 to 0.5 milliamps. At this stimulus, the needle tip will be 1 to 2 millimeters from the nerve. Reposition the needle if opening injection pressure is more than 15 psi. Avoid excessive needle passes or injections. Use short bevel needles. Bolus observe and reposition needle. Intraoperative measures. Test for sensory and/or motor block prior to inflation of tourniquet and surgical incision. Full monitoring as with general anesthesia. Beware of local anesthetic toxicity. Separate the patient from the surgical site with a screen. Use appropriate sedation. Check patient regularly for pain or discomfort. Always be prepared to convert to GA or abandon surgery should local anesthesia fails. Post-operative care includes protection of the operative site from injury, such as using an arm sling for a limb with residual motor or sensory blockade, adequate preloading with analgesia, provide information to the patient on the timing of return of sensation and motor function, provide contact information to the patient for any queries that the patient might have. Patients with complications that may be due to nerve blocks should be reviewed by appropriate specialists. Interscalene Brachial Plexus block. Interscalene local anesthesia blocks the anterior primary rami of the nerves of C5 to C8 and T1. Indications include anesthesia for shoulder surgery and proximal arm surgery, and analgesia for shoulder surgery, proximal arm surgery, and physiotherapy or mobilization for shoulder conditions such as frozen shoulder. Advantages include it is the only approach to the brachial plexus that blocks the suprascapular nerve reliably, which provides sensory supply to the shoulder. The most proximal approach to the brachial plexus is the interscalene block. Disadvantages of the interscalene block. It is less suitable for surgery of the hand or distal arm, as it does not block the C7 to T1 nerve roots reliably, even when LA is more than 40 mils. Ulnar sparing is frequent, up to 30 to 40%. It does not reliably block the C4. Superficial cervical plexus may need to be blocked for skin anesthesia over the shoulder. With volumes of 25 to 30 mils, interscalene injection might extend to block the cervical plexus roots C3 and C4. Adverse effects. Phrenic nerve block occurs almost universally, up to 90%. Ultrasound guidance and LA doses of 5 to 10 mils to target C5 to C6 nerve roots for post-op analgesia reduces phrenic nerve block. There will be a 25 to 30% reduction in functional residual capacity. Bilateral blocks should not be performed due to risk of respiratory failure. Pneumothorax occurs in 0.2%, Horner syndrome up to 20%, recurrent laryngeal nerve block up to 15%, vertebral artery puncture. The vertebral artery lies anterior medial to the plexus. It is vulnerable to intravascular injection. Seizures may occur if LA is injected into the vertebral artery. Inject 1 mil and pause before injecting the remainder. Intrathecal, epidural, and intracord injection. Neurological injury. 0.2% has permanent injury. Temporary paresthesia, dysesthesia, or pain occurs in 8 to 14% at 10 days, 3.7% at 1 month, 0.6 to 0.9% at 6 months. LA toxicity. Perform interscalene brachial plexus blocks on awake or lightly sedated patients only, as all cases of serious complications relating to LA injection into the central neuraxis occurred when patients were asleep for their block. Document good reasons why the block was forced to be performed on an anesthetized patient if it occurs. Specific contraindications includes contralateral phrenic nerve palsy, contralateral recurrent laryngeal nerve palsy, severe respiratory disease. Choice of local anesthetic includes lidocaine 1.5% with adrenaline 1 in 200,000, bupivacaine, ropivacaine, or levobupivacaine at 0.2 to 0.5%. More dilute solutions are necessary when larger volumes or additional nerve blocks are required. When the block is combined with general anesthesia, or when post-operative local anesthetic infusion is planned. Ultrasound technique. Ultrasound settings. Use a high frequency more than 10 MHz linear probe set at 2 to 3 cm depth with an axial orientation and a chordate angulation. The needle should be 25 to 50 millimeters of choice. Scan findings. Identify the plexus by scanning from the supraclavicular fossa cephalate. Ultrasound probe placed parallel and behind the clavicle. Identify the subclavian artery and trunks divisions of the brachial plexus. Scan cephalate to follow the nerves proximally until the anterior and middle scalenes are visible. The plexus will appear as hypoechoic, round, oval structures. Angle the probe slightly chordate. The nerves passes laterally towards the first rib, following the scalenes. Other structures that can be seen at this level include the phrenic nerve, which lies close to the C5 nerve root, lying on the anterior scalene beneath the prevertebral fascia. The supraclavicular artery crossing the anterior scalene. Deeper structures, the transverse processes of vertebrae, vertebral artery in between the transverse foramina of the upper 6 cervical vertebrae at the lateral aspects of the vertebral bodies anterior to the emerging nerve roots. Patient positioning. Supine with head turned 45 degrees to the contralateral side. The machine at the contralateral side. Operator at the side of the nerves to be blocked. Or lateral position with the block side up, machine in front of the patient and operator behind the patient. Needle approach can be in plane or out of plane. Approach the needle medially. The needle passes through anterior scalene. If the needle is approached laterally, the needle passes through the middle scalene. There is a risk of damage to the dorsal scapula and the long thoracic nerves when the in-plane method is used. These nerves are hard to identify on ultrasound. Damage to these nerves result in disabling motor weakness and a wing scapula. Use a nerve stimulator. If scapular movement occurs at 0.2 mA, reposition the needle. The out-of-plane method mimics Mayer's approach for landmark technique. Follow the general measures as detailed previously, which includes assessment, consent, monitoring equipment, assistant, clean and drape, asepsis, sedation, analgesia, etc. For shoulder surgery, only the C5 and C6 nerve roots need to be blocked. Perform the block proximally to ensure blockade of the suprascapular and dorsal scapular nerve. After negative aspiration, inject 1 ml of LA and observe for spread. There may be a need to position the needle on the other side of the plexus. 5 to 10 ml of LA targeted around the C5 and C6 nerve roots is sufficient for post-op pain relief. Superficial cervical plexus may need to be blocked separately. Typically, an interscalene block will last for 12 to 16 hours. Adding dexamethasone to the LA solution prolongs the block. IV dexamethasone also prolongs the block, and since dexamethasone is neurotoxic, IV dexamethasone is preferred. Peripheral nerve stimulator technique or landmark technique. The endpoints for nerve stimulation: impulse duration at 0.1 millisecond, stimulating current at 0.2 milliamps to 0.5 milliamps. Biceps contraction, triceps, and deltoid contraction are acceptable endpoints for nerve stimulation. Diaphragm contraction, needle positioning is too anterior, stimulating the phrenic nerve. Redirect the needle more posteriorly. If rhomboid muscle contraction occurs, signified by shoulder and scapular movement, needle position is too posterior, stimulating the dorsal scapular nerve, which lies posterior to the middle scalene. Redirect the needle more anteriorly. If scapular and shoulder movement occurs, the nerve to levator scapulae is stimulated. Redirect the needle anteriorly and more caudate. If trapezius muscle contraction occurs, the accessory nerve is stimulated. Redirect the needle caudate and anteriorly. The Winnie's approach. Fingers on the left hand are palpating the interscalene groove. The needle is inserted at the level of C6, aiming towards the contralateral elbow. Follow the general measures as detailed. Identification of the interscalene groove. The interscalene groove lies between the scalenus anterior and medius at the level of the cricoid cartilage at C6. The anterior scalene lies immediately behind the posterior border of the clavicular head of the sternocleidomastoid. To make the groove more prominent, ask the patient to lift the head off the pillow or turn the head to the contralateral side and ask the patient to take a deep, slow breath or sniff. Up to 90% of subjects, the external jugular vein overlies the groove at this level. Needle insertion. A 25 mm 22 gauge stimulating needle is used. The needle is held perpendicular to the skin in all planes. It is directed medially, posteriorly, and caudally towards the transverse process of C6, known as the Chaksenex tubercle, in the interscalene groove at the level of the cricoid cartilage C6. The plexus is rarely more than 2 cm deep at this level. The needle should not be inserted more than 2.5 cm. Once acceptable muscle stimulation is noted, 25 to 30 ml of LA is injected in 5 ml aliquots after aspiration with all due precautions. The Mayer's approach. The needle is directed caudate and lateral at the C4 level, marked by the thyroid notch, down the interscalene groove at 30 degrees angle to the skin, towards a point just lateral to the subclavian artery pulsation. The subclavian artery is palpable in only 50% of subjects. If it is not palpable, use the midclavicular point as the lower landmark or a Doppler probe. Needle of choice is a 50 mm 22 gauge stimulating needle. Since the needle is directed laterally away from the midline, this reduces the chance of damage to the central neurexis or vertebral artery. This tangential approach facilitates catheter insertion as well. The plexus should be found at a depth of 3 to 4 centimeters. Once acceptable nerve stimulation is noted, 25 to 30 mL of LA is injected in 5 ml aliquots after aspiration and with all due precautions. These are my references. Thank you.